Yeah, I think we can start then, Bilal. So a very good afternoon, everybody. This is the second for 2025 in our series of lectures in pediatric radiation oncology, which are presented to you as a combined effort between the Essen Proton Center and the PROS-ALMIC group, which is part of SIAP Global Health Network. So we have about 90 people online, and our speaker today, we're very privileged to have Sarah Peters. She is talking about radiotherapy in EPENDYMOMA for us today. So Sarah has been, since qualifying at the University Center in Essen, the Proton Center in Essen, where most of her work is centered around treating children with protons. And she's going to take us through the use of radiotherapy for pediatric ependymoma in the brain and the spine today. So welcome, Sarah, and thank you very much for joining us today and sharing with us your expertise.
Yeah, thank you. Good afternoon or hello to everyone wherever you are. Thank you. Special thank you to PROS and all the members of the committee and panel to have me here this afternoon to talk about this very difficult and interesting topic. What I like to do is to give a brief introduction and then focus on the treatment of newly diagnosed intracranial ependymoma, as well as the situation of disease recurrence, and later also talk a bit about how we treat spinal ependymoma. I hope that in the end we will have a lot of time for your questions and for discussions. So please do not hesitate to write questions in the chat that will be monitored. To start, when we talk about ependymoma, we talk about a rare disease, but very common among the pediatric ZNS tumors. We have a peak in the pediatric community lower than primary school age, and the incidence and mortality also differs among these groups, but also among different ethnic groups, as we see somewhat lower incidences, for example, in American population of African descent, but they might also have increased risks of, for example, survival compared to other parts of the population. The location for pediatric patients is mostly intracranial, but we also see spinal disease in children that might be associated also with some other diseases, for example, like neurofibromatosis. The symptoms depend obviously on the location, and we would prefer a workup of imaging, preferably with an MRI scan at the beginning that includes the head and the spine, and an examination of the craniospinal fluid, which ideally takes place 2 weeks after surgery. Surgery is unavoidable and often also necessary in a short time, depending on the symptoms presented that might interfere with our preferred imaging workup. When we do surgery, we aim for gross total resection, as we will discuss later going on. Afterwards, treatment should follow international protocol, for example, SIAP ependymoma 2 or others, depending on local availability. We now know that we don't talk about a heterogeneous group, but get more and more understanding about the different molecular subgroups and how they can affect our outcome for our patients. The shape of what we see as ependymoma has changed during the last decades, and we understand better that there are different types of tumor risks associated with tumors coming from the same area, for example, AMB posterior ependymoma. This change of understanding led to the new reclassification in the 2021 issue of the World Health Examination. And we see that with different subgroups, different outcomes are associated. We see that some have a fairly poor expected overall survival, while others might have a better or more beneficial course of disease. So when we now move further on, what are the open questions in the treatment of ependymoma? And maybe there are more than one can answer. When we discuss about radiotherapy, we often ask ourselves, is what we give is enough, or do patients need a dose escalation, for example, as a boost to residual disease? The value of chemotherapy is still under investigation and discussion for only partial resectable tumor prior to radiation treatment or during the course of follow-up. Prognostic factors have been examined in length in publications, but some might also be influenced by the new emerging pathological subgroups. And our patients with spinal ependymoma at pediatric age also still are under investigation what the best course of individualized treatment is for them. When it comes to tumor recurrence, depending on the type of tumor recurrence, the best way of radiation treatment is also still under discussion, and we will discuss about this in the third part. So when we now go to treat newly diagnosed ependymoma, there are all standard guidelines recommend to go for the maximum safe resection and add fractionated focal radiotherapy if we are talking about a non-metastatic situation. We know that the extent of surgery is an important factor for the outcome of our patients, and that radiotherapy, normally we aim to start most in a short period of time after treatment, after surgery. We also give radiotherapy to young children as early as 12 to 16 months. We should consider it, and radiotherapy to the craniospinal cord in a primary setting is more reserved for primary metastatic disease. The classic risk factors, when we look through literature that are discussed, are mostly age, also gender, and the old WHO classification before the change of 2021, and that we have to keep in mind when we look at all the data. Of course, initial metastatic disease is a risk factor for a poorer outcome, and the origin, meaning the location in the craniospinal spinal system, is an important factor as well. When we now focus on the extent of surgery, we have multiple analysis aiming back to the early 2000 years that all showed that the extent of surgery is an important factor in the for overall or event-free survival in this group of patients. This is a graph that focuses on this a bit better. This is a more recent publication from 2022, which analyzed data from the SIOP ependymoma 1 trial. And here you see the event-free survival and the time on the baseline, and we see that the patient in the red that received a gross total resection had a significant better event-free survival compared to the patients that only achieved subtotal resection. Of note to this study is that for the overall survival, they could not show that STR was a significant factor in the multivariate analysis. Only the grade 3 tumor type, according to the older classification, was of significance there. When we treat ependymoma, we would prefer to use the highest conformal technique that is available to us, that might include IMRT, VMAT, or proton therapy when available. In situation when we talk about boosting residual disease, or in palliative settings of a recurrent patient, also techniques like like radiosurgery might come to use. The timing is something that has been discussed to length when to start radiotherapy, and the general recommendations in the ACNS and SIOP protocols is to start early after surgery. This graph that you can see on this slide shows an experience from Iran, lower middle income country, showing a significant worse outcome when RT was delayed more than 77 days after surgery in their cohort that was published recently. Other analysis from, for example, the cancer database, the National Cancer Database of the US, that examined a big group of more than 1,000 patients, failed to show a difference, at least for overall survival, in patients treated within 5 to 8 weeks or longer than 8 weeks after surgery, while effect on event-free survival could not be examined with the data available there. When we have very little children falling sick within the first year of life, then chemotherapy should be considered to bridge bridge the gap until the end of the first year of life. And in cases of residual disease, so a subtotal resection, also the value of chemotherapy is examined in current protocols, and we are awaiting the results there. The age of for radiotherapy what was discussed before, but we see that children also that are treated before they reach the third year of life can achieve similar outcomes than children treated when they are older than 3 years, if we not postpone radiation treatment. So what is it that we are treating? We, of course, try to use the target volume based on the CT, and ideally with MRI imaging prior and post radiotherapy. The tumor bed is then built out of that, and we would consider a reduction of the CTV, a margin of 5 millimeters to 2 to 3 millimeters towards the brainstem for the fossa posterior ependymomas, in case we don't have an infiltration of the brainstem. The PTV margin is, of course, depending on the local policies, and normally in the range of 3 to 5 millimeters if the precision of your positioning systems and calculations allows that. What you see here on the right-hand side of this slide is the, our in-house concept that was also published before, that we use for patients that are not treated in trials. Here we use a differentiation between patients that are younger or older, 4 years of age, which comes to effect in the when it comes for the CTV2, which we use after 54 gray, when we cone down to either a tumor bed or just the GTV2 to reduce the volume for our younger patients. To give an example of what that means in an older patient, I brought for you a 9-year-old patient that was presented to us with the first diagnosis of a ependymoma. The tumor was resected from the fossa posterior, but initially, which you see on the MRI scan here, we had an extensive disease that compromised and deformed the brainstem massively, and this deformation of brainstem was not completely resolved after the relaxation of removal of the tumor. So what we see here is our tumor bed, which is also marked as CTV2 with the blue contour, and our CTV1, which had the initial margin, obviously compromised to natural borders, as for example bone, but also reduced a bit towards the brainstem, which was not infiltrated in this case. After 54 gray, this is what you see in the dose coverage here. We reduced our target volume to the tumor bed and also spared a bit of the brain stem. When we talk about dose prescription of EPENDYMOMA, when we talk about dose prescription for EPENDYMOMA, we normally talk about in the primary situation about a fractionated radiotherapy of 30 to 33 fractions to a total dose of 54 to 59.4 gray. There is a lack of randomized trials really proving if we need 59.4 or if there are patients that are sufficiently treated with 54 gray. Also, the other direction of an extension of treatment for patients with a residual with a way of a stereotactic boost was investigated in the recently closed CEOP EPENDYMOMA 2 protocol. We would consider caution in case and consider dose limitations, especially for very young patients, younger than 18 months, or with severe neurological symptoms, especially after surgery, or where multiple surgeries had to be performed to see this status. Also, literature looked at this in experiences if either more or less than 54 or more or less than 59, 9.4 gray was beneficial, and they were not able to show an actual benefit of a dose escalation. The most recent study from 2025 found a trend towards a worse 5-year OS and PFS among patients with the EPENDYMOMA grade 2 who had only received 54 gray. So this is something that would be interesting to examine in more detail in the stratified randomized trial. To go back to what we've done in Europe during the recent years with the recently closed CEOP EPENDYMOMA 2 trial that had basically 3 strata, which included the one for the little patients younger than 1 year who received a first randomized chemotherapy protocol, and patients older than 12 months were either in a randomized for additional chemotherapy when they received complete resection and radiation therapy, or for patients who were not able to receive a gross total resection in the first attempt, we had a randomization for chemotherapy and the boost treatment afterwards. No residual tumor was defined as not measurable in 3 directions on lower than 5 millimeters. And as we discussed before, start of radiotherapy was therefore recommended within 6 weeks of treatment. This trial treated with 59.4 gray for the local site. But as mentioned before, in cases of severe risk for side effects, for example, brainstem toxicity, dose reduction was considered. In case of a measurable tumor residual after the first surgery, there was a randomization for the chemotherapy with or without methotrexate, and after that, the resectability was reassessed and performed whenever feasible. After that, local RT followed, And if there was still remaining residual after the surgical procedures, a stereotactical boost using 2 times for gray was performed. When we now talk about prognosis of outcome for our patients with non-metastatic ependymoма in the recent years, we see in this meta-analysis that we have fairly high survival rates at the beginning, but a wide range after a longer time, and they can range from 50 to up to 80%, depending on where you look. This meta-analysis found some sort of benefit trending towards proton beam therapy, but also the studied included, for example, in the proton therapy arm was in parts much older, and that might affect comparability. We show also some of our own results. We analyzed 105 of our own patients that were the first ependymomas patients that we treated here, and we see that overall survival and local as well as progression-free survival is comparable to what we just saw before in the literature. This is just an in-house study, so for that reason it lacks stratification in risk, and it's not a randomized trial, but gives a good idea. And we performed analyzation for risk factors and found multiple tumor surgeries in our cohort to be significantly associated with a poorer progression-free survival. All of what I showed you before comes back to the first slide that we get, that with the 2021 reclassification of the WHO, we get more and more insight of how important or what effect these tumor types have on our of our outcomes. This is a publication and a reanalyzation of a patient cohort from the CEOP ependymoma 1 study, where the event-free survival was, as expected, worse for our patients with PFA and ZFTA ependymoma. They also found that the 1Q gain and the third transformation was associated with a poorer outcome, as we would expect. When it comes to post-radiation chemotherapy, the role is still under discussion. As I told you before, it is also part of the examination of CEOP ependymoma 2, but also of the American ACNS 0831 trial. There was recently published some data where they had an analysis of the 3-year event-free survival with chemotherapy post-radiation. And what was interesting was that of the patient they had randomized to the 2 arms, they had a lack of adherence to their randomization profile, about 30.5%. That means the compliance was fairly low. In the first planned examination of the trial data, which was an intention to treat analysis, there was no significant difference among the 2 groups. But when they reanalyzed for actually treated patients, they found some significant difference with 80% better with a better event-free survival of 80% for the patient that received actually any sort of chemotherapy, leading the authors to the suggestion to discuss again chemotherapy for certain subgroup at least. When we talk now about the situation of recurrent, which is a frequent issue, it leads us back to our classification of ependymoma. We see progression-free survival differences between very poor of 25 to 75% in literature, and we see local recurrence as well as dissemination. Here we see an examination of data of more than 200 patients that have, where we see that the highest risk for distant or combined failure was in ZFDA, EPNB and EPNA patients. What they also found in this cohort is that the risk of metastatic disease to the spinal canal was much higher in patients with an fossa inferior tumor compared to the ZFTA cohort. When we treat local recurrence, the way how to treat this is under discussion, but what we should aim for is to repeat the staging as we've done it in the initial situation. So when it's possible, repeat the full craniospinal MRI and get liquor if possible. We should aim for surgery if it's feasible, and if we should aim for gross total resection. The pictures I show you here is a graph of the survival after the second time of radiotherapy, and it shows the survival probability for patients that received a gross total resection or not. Red is here for the patient that received gross total, and blue coded for less. And they found this study of Magia found that the extension of surgery was significantly associated with the outcome of these patients. The treatment of should then at least consider adjuvant radiotherapy. The extension of adjuvant radiotherapy, especially in a local recurrent situation, is something that is under discussion from my point of view. Especially if there are high-risk features, as I said before, not complete resection of the residual tumor, and also a short interval after the first treatment, radiotherapy should at least be considered. Some studies suggest that it is beneficial in all patients. Analysis of the HIT-RETS register, which is a registry for recurrent diseases based in Germany, they could not show a benefit for patients that had a gross total resection, but radiation was beneficial for patients that did not achieve gross total resection in this analysis. Another thing that is discussed is if local re-irradiation, and in the case of local recurrence, is sufficient, or also an CSI treatment, so a whole craniospinal radiation should be considered. We have some studies that includes also the Mackendal study that I presented 2 slides before, and this one that show some benefit for CSI treatment. The risk is that, or the issue is that this is often low numbers. In this case, only 7 patients received the radiation treatment, and compared to a also low numbered comparison group. We also miss the detailed analysis, pathological analysis according to the new WHO classification, and a risk stratification that could influence the outcome of our patients, especially if we have only these small numbers. What we do in case of a local recurrence at our center is show you a case again here of a young patient that had his initial diagnosis of at the age of almost 3 years, and in first line RT was omitted by the choice of the treating hospital at that time, and we started to treat in the time in the case of second recurrence when there was a complete resection, and after another 3 years we saw another local recurrence, which was then treated again with radiotherapy. You see on the top the plan of the second residual. So this is the boost volume that or the volume that we treated with 54 gray in the case of basically the third recurrence. And on the bottom, you see the sum plan of these 2 plans that were treated initially. So therefore, the highest doses here was beneficial because we had some space towards the brainstem. From our experience, which we looked at in the last years, we treated most of our local, we treated all of our local recurrent patient with focal radiotherapy, but we saw that 3 of them had a metastatic, or 50% developed a metastatic recurrence afterwards. In case of a metastatic relapse, so that we already find a combined or isolated metastatic disease, we would more go in the direction of craniospinal radiation and consider boost to residual size, to residual types. Also, an interesting experience from St. Jude's showed that the patients who suffer only a distant failure only metastatic recurrence can have comparable results when going to for CSI treatment in this situation. As well, they could show that the 1Q loss was 1Q gain was associated with the poorer outcome, especially for overall survival. So to close the loop of what we saw before is this analysis of the first, the follow-up after first relapse, depending on the ependymomas subtype. And here I want to emphasize the timeline on the base that we are talking here in years, not months. And we see some long-term survivor after first after first recurrence, but the curve is lower for EPNA and ZFTA ependymoma. What the authors also saw is that at the beginning, the 5-year overall survival in our EPNV group is very high, but after 10 years, it drops significantly. Even if it's the majority, still roughly 10% of our ependymoma patients can have an initial spinal ependymoma in a pediatric community. And the long-term prognosis for them is, on average, it's very good. But we know that there is distinct subtypes with, for example, McGann amplification that are associated with an aggressive course of disease, high rates of recurrence in short distance to primary treatment, and poor overall survival. Still, in general, we would apply again to aim for GTR, and we would also want all of our patients to be staged sufficiently similar to the intracranial location. This is an analysis again on the benefit of the extension of surgery for this cohort. And in this big analysis, they also found that surgery had the most significant influence as a prognostic factor, as well as invasive growth, but could not show a benefit for radiation treatment in general. This leads also to this slide that I wanted to show you, which shows some treatment practice recommendation just recently published from SIOP that show Europe that show our pathway depending on ependymoma subtype. We would aim for complete surgery in all of our patients and reconsider secondary surgery in case of incomplete resection. For the EPN type, if we can, we would continue with the watchful waiting strategy in case we have a not metastatic disease, and in case of metastasis, that should be discussed, what the extent shall be and how extensive the metastatic progression is. Often we see it is along the spinal canal, and then radiotherapy should be addressed accordingly. For the medium group, we would follow the same and also go for watch and wait for strategy, but in case for relapse, then go towards the radiotherapy path. A bit of an exemption is our MUC-N amplified cohort with, as I said, mentioned before, high risk of recurrence and high risk of recurrence and poor outcome, where we would consider radiotherapy already at primary diagnosis, and would also at least discuss a CSI, and in case of metastatic situation would also tend to go that way, at least for children that are of age where it's feasible. In order to sum this up and have the sufficient time to discuss questions, the core principle would be maximal safe resection and a technique, of course, adapted to availability, but as conformal as possible. There are, as I might hopefully showed you, a lot of open questions that also depend on the type of a type of pathology that we have in each patient. So stratified trials as for the newly diagnosed ependymoma, as well as for the metastatic disease, are desirable and at least under conception. Also our interspinal ependymoma shall not be forgotten, and there also prospective studies would be desirable, but because of the low numbers, at least registering them is of uttermost importance. I hope it was interesting for you, and I'm more than happy to discuss any questions with you and our panel. Thank you so much for your attention, and of course, thank you all of our colleagues at the Proton Center here and the panel.
Thank you, Dr. Sarah. Yate, would you like to lead the question and answers?
Yes, great, thank you. So sorry, I was a little late. So we have some questions in the chat. First one is, what is your brainstem dose constraint while your CTV expand 2 to 3 millimeter into the brainstem? So what brainstem constraints do you use?
So yeah, so for the brainstem, we use them according to the protocol, which tend to be a bit higher in the SIOP ependymoma 2. If we treat patients off the protocol, we go not higher than 55.5 or at uttermost 56 in the max if we aim at 59.4.
The second question is for a young 18-year-old female patient with lower spinal ependymoma, resected, no residual, no surgery. What dose constraints would you put on the ovaries?
Yeah, that's great questions for the. So if you are to go for radiation treatment at this time point. It was not resected. Did I get this right?
No, but I wonder why this is relevant. I think it's on dose constraint. So what is the dose constraint for the ovary? Maybe this is more a general question.
Okay, yeah.
So I don't
So
think you need to refer to the details of the case.
we go as low as feasible, but we try to stay below 10. But with
Yeah, so maybe I can add to this. So typical, so if we can, we try to keep below 2 gray. We try to keep at least below 5 gray because we know above, let's say, 10 gray risk is really increasing. But I think it's difficult to give a clear answer also because it's age dependent. But we try typically as low as possible. But with protons, it's easy. So with protons, typically we achieve below 2 gray.
Yeah.
For Peters, I hope that is okay.
Yeah, exactly. So that's why I was a bit, yeah. It depends how urgent it is to irradiate now, and if you don't have protons, then might be difficult to achieve these doses.
So do you have a specific time point for radiotherapy in supratentorial ependymoma? So when would you irradiate a supratentorial ependymoma? Maybe it's not about time point, maybe it's really about indication.
So a supratentorial ependymoma, we would also irradiate, especially if it's a ZFTA tumor. At the moment, we do not really have an open trial that spares some of the malignant supratentorial ependymoma from receiving radiation therapy right away, even though there are some studies, especially YAP ependymoma can also be salvaged with radiotherapy at the first relapse.
Then there is one, let's say, logistical question. Is there a certificate for the webinar? I don't think so, Bilal, that we have something like this so far.
No, that's right. We do not have a certificate.
Maybe we can discuss later on if we want to have something like this, but so far we don't have it, unfortunately. In the SIOP ependymoma 2 protocol, is there risk stratification for molecular subtypes like PFA or PFB? And is this integrated into the decision making?
Unfortunately, we don't have that yet, but we try to collect this data from our pathologists, and the ongoing evaluation of the data we have so far is probably the base of the hopefully coming soon next SIOP ependymoma 3 trial.
Thank you. Do we have any long-term data on neurological sequelae in radiation dose escalated cohort in ependymoma 2 protocol?
No, because the SIOP ependymoma 2 protocol just closed this spring, so long-term neurocognitive data, I'm not aware that we have that yet from that trial.
Yeah, I haven't seen that either. However, in all strata, there is neuropsychological testing included. So I hope at some time point we will have it, but I don't think we have it, or at least we don't have seen it so far, and we need to wait for some longer follow-up times. For a spinal ependymoma, even if it is R1 resection, would you omit radiotherapy?
I would make it a bit dependent on the molecular subtype if available. And of course, also the availability and adherence to follow-up. So if you seek a watch and wait therapy, of course, that should include at least some sort of regular MRI in my point of view.
What are the considerations and potential implications of CSI in a palliative setting for a patient with unresectable posterior fossa ependymoma having multiple spinal metastases?
So the considerations would be to give stop tumor growth that might affect the metastasis to grow, in the sense that they lead to neurological outfalls of the extremities and therefore restore quality of life. I think this is something that can be considered depending on the patient status and in close considerations with pediatric oncologists.
Yeah, we just had a discussion yesterday, Frau Peters, maybe I may add that
Of course.
said we have very limited data on the effectiveness and the benefit of CSI in such a setting. And there may be people who would, depending on the general status of the patient, maybe even prefer to give only local therapy to the areas of symptoms or threat of symptoms. So I think evidence-wise is very difficult to answer. However, in the German guideline, in a M+ situation, it would be proposed. But as Dr. Peters is saying, I think this need also careful discussion with family, because of course CSI also has toxicity, and therefore if the general condition is poor and family does not want to go into toxicity or bone marrow depression, etc., of course this need to be discussed. So I don't think this is a black and white situation. In case of another question, in case of absence of protons in subtotal resection, would you boost to 15 or above 59.4 gray?
I think with modern IMRT techniques, at least it is possible to treat under to 59.4 gray, and with radiosurgery and a good gamma knife also, depending on the localization, also a boost could be considered, but we don't perform a boost above 59.4 outside of the EPENDYMOMA protocol. But for this protocol, the proton therapy was not mandatory. So we had what might be added for this protocol is that we had a review. That means radiation plans were revised by the reference hospital, and but so that there was some sort of quality assurance, but proton therapy was not mandatory, and we don't give the boost above 59.4 outside of protocol.
Bilal, do you want to comment on this?
No, that's right. I think with the availability of volumetric modulated arc therapy and IMRT, a dose up to 59.4 is very much possible. And I would absolutely agree that outside the setting of a trial, I would not boost beyond that, be it stereotactic or a conventional treatment.
We have a lot of questions. This is really nice. I think the interest is really very high in this topic. So is there any recommendation for PFA 1Q gain and 6Q loss?
So unfortunately now we have not a recommendation yet for radiation treatment that goes outside of the standard, but of course this is something that would be desirable and should be certainly a question in new randomized trials.
Yeah, so Bilal or Jeanette, do you have in your places strategies taking those factors into account for an ependymoma? So in Germany, we don't have that at the moment? No,
No.
Okay, they don't have it. Yeah, so I think we are a little bit behind to do risk stratification according to the molecular subgroup. So I think this is really something which is to come. The next question, what strategy is recommended for patient aged 12 to 18 months with metastatic disease? So very young child with metastatic disease.
So I would consider this age too young to treat with a craniospinal disease. So there should be chemotherapy strategy should be considered in case of symptomatic metastasis. This radiation treatment according to that should also be considered.
Yeah, so we try to avoid at very young age or delay radiotherapy. And if radiotherapy is given, then typically with a reduced dose to the craniospinal or focal radiotherapy only in infants. Since ependymoma gets only local radiotherapy, what late effects are expected? And also, what all do you monitor after therapy? Do you have baseline hormonal or hearing testing, follow-up scans, just MRI from head or also spine at every visit?
So what we recommend for the organs at risk is depending on the dose that these organs actually had. We have for fossa posterior, I would always recommend the hearing to be tested, and for supratentorial also of eyesight and hormonal status, which we recommend normally annually if there's nothing special. For the imaging, I would recommend the MRI scan of the head in the European recommendations as every 3 months for the first year, and then goes down in intervals up to yearly after 5 years. And at the beginning, also annually, an MRI scan of the whole craniospinal cord should be considered.
Thank you. There's another question. What is the optimal radiotherapy volume in an ependymoma with local recurrence based on your institutional experience?
We take the residual and sometimes apply small CTV margins if possible and feasible, but not more than 5 millimeters. And this is also depending really on tumor site and possible left dose.
And there's a question on the same issue. So in case of local recurrence and gross total resection of that recurrence, would you re-irradiate?
So for that, we look a bit more at the risk factors. According to the German data, we sometimes do not irradiate immediately and do follow up, but there we take also other risk factors into account. This is but a bit of a German look at it.
Bilal? Sorry, Bilal?
Yeah, yeah. I think in LMIC and in many resource limited settings, re-radiation is often a question, because radiation may be easier to do when VMAT is available and surgery is not, a gross total resection is not achievable. So maybe Dr. Beate or Dr. Sarah, you want to highlight on that. Yes, we have data on re-radiation, but who are the patient who benefit the most from re-radiation? I believe a gross total or a near total resection holds great importance when making a decision for re-radiation and expecting good outcomes out of that decision.
Hoppe, does you want to comment on that?
I had to just, I'm sorry, I didn't get the.
So
No.
I think the question is, when is it most beneficial to irradiate? And I think from the data we have, it's more in the subtotal resected
exactly.
recurrences. We have less data on benefit in gross total resection. Still, I would say we don't have really the clear proof if that is correct. And we are also at the moment discussing strategies for recurrent ependymomas. I would say internationally do not fully agree. I think we agree in subtotal resection, but we don't agree in gross total resection. And the proof has to come if we can omit radiotherapy after gross total resection. However, it seems, I would say, benefit is less proven to my understanding. Frau Peters, I don't know if you want to agree or if you would agree.
No, I think I agree, would agree, and just would add that it's our homework to also include the new pathological subtypes to further specify if we can identify people who can be omitted or not, because often in the published data, the cohorts are so small, often comparing less than 10 patients in one subgroup, and then this is often difficult to interpret it.
So unfortunately, we have really a long list of questions. We cannot finish them all in time. So maybe I just pick one last question. So any difference for the CTV margin after gross total resection or subtotal resection? Do you use the same CTV margin or different margins?
No, we don't alter the margins depending on the type of resection. We use
but
depending on the patient type, we would change the dose, especially in the younger patients, which will boost until 59.4 if feasible.
Yeah, and the boost we give to a smaller
volume
without CTV margin. So if we go higher, we typically do a cone down to become smaller for the high dose. I think this is, we have published this Frau Peters has published this together with myself. And I think a similar paper with a similar strategy was also published by Denny and Delicato. They also do a cone down, I think, if they go above 54. So I think in order to be feasible in that very young age group, it's always good to be very restrictive with your margins and your volumes. So I think, unfortunately, we cannot finish because it's still a long, long list. We cannot finish all questions. So maybe Bilal or Jeanette, you want to close the webinar?
Jeanette?
Bilal, I was going to leave it up to you.
Oh, that's fine. Yeah, so just thought we had a similar long list of questions for during our last webinar too. So maybe I thought that we extend the time at least to 80 minutes so that we can cover these questions in the future lecture. That's a thought from my side as we plan for the meetings. And what we did last time too, Beate, we compiled that list of questions and you and Arnold helped answer some of those questions. So is there a possibility to do that for today's meeting too?
Yeah, so if someone would provide us the list, then Mrs. Peters and we would be ready to answer the questions in written format, and we can distribute it to the participants.
Okay, I have them copied with me, so I'm happy to do it and send them to you.
Okay, great.
Thank you.
Okay. Thank you again to all those who attended. We have had a maximum participation of more than 150 seen today. In fact, 160 I saw. So it is very widely attended, more than 30 questions, very interesting and all having their own importance. So thank you, Beate, for leading this effort. Thank you, Dr. Sarah Peters, for sparing your time and all the efforts in giving this talk, and Dr. Janet Parks for chairing this along with Beate, and of course our organizers of GHN, the West Germany Proton Essen, and cross working group of GHN. Thank you so much for attending. Bye.
Bye.
Bye.